Welcome to episode 3 of the Walk and Talk Improvement podcast series. In this episode, we're going to explore improvement efforts to address one of the most common causes of patient harm. That is, recognizing and responding to the clinically deteriorating patient. Topics you'll hear about include the importance of clinical judgment, communication between staff as well as communication with patients and families, safe systems and safe culture, as well as personal experiences and examples of successful improvement efforts that have made a difference. I'm Roisin Egenton. I'm a Programme Manager in the HSE National Quality and Patient Safety Directorate, and I've been working in the areas of quality improvement and healthcare audit in the HSE for almost 12 years. In this episode, I'm joined by Yvonne, a project lead in the HSE National Deteriorating Patient Improvement Programme, Sheehan, an advanced nurse practitioner in critical care outreach, and Dr. McCloskey, a consultant in anaesthetics and intensive care medicine, who is also the patient safety and quality improvement lead in the NHS Belfast Trust and the Director of Patient Safety and Quality Improvement at the College of Anaesthesiologists of Ireland. First up, I met Yvonne and Christine at Merlin Park University Hospital in Galway. And Yvonne, come to you first. The recognition and response to the clinically deteriorating patient. Why do you feel that is still a high priority patient safety area in Ireland?
Thanks, Roisin, and thanks for inviting me to speak on this such important topic. And I think it's very dear to all healthcare workers' hearts. I think it has to be higher on a priority because not only do we have an ageing population, but we have a cohort of patients out there who are living longer with multiple comorbidities and increasing acuity. So I think it's important not only to have systems and protocols in place to keep our patients safe, but also to make it easy for our staff to work safely so that they can go in and do their job and be safe. And also that there's guidance there, when things go wrong or when a patient does deteriorate. Because we do know that acute deterioration is a time-critical emergency, and failure to detect and treat patient deterioration in a timely manner poses a threat to patient safety. And of course, this can lead to many adverse outcomes such as cardiopulmonary arrest or anticipated critical care admissions. And I think that it's a really important topic, and as I said earlier, it's dear to a lot of healthcare workers' hearts, but also there's a real appetite out there, from healthcare workers, from working with them and speaking with them. They want to know, they want to be educated, they want to be trained, they want to know how to recognise a patient, and when they do recognise, how to escalate.
And Yvonne, do you have personal experience in working in this area?
I do. So I'm a nurse, and I remember I qualified actually before the early warning score first came in, and the first guideline was published in 2013. And I remember actually having much more exposure to cardiopulmonary arrests. My very first experience was actually a cardiac arrest and a respiratory arrest at the same time as a student nurse in an acute medical ward. And, I've never seen that since, especially since after, the early warning score came in. And of course, now we have the iNews, which is an improvement and advancement of the early warning score. And I think this, nothing will ever be perfect, but, I think it's important that we look at improvements and advancements and bring them and, give access to training and education and staff. And I think that, also with iNews, it also embraces that, clinical expertise, that clinical judgment. The patient might necessarily be triggering, with their vital signs yet, but there may be many soft signs of deterioration.
Okay, and Yvonne, for people that might not know, what is the iNews?
So the iNews is the Irish National Early Warning System. So it's a system we used to, you probably remember the early warning score, but it's more than a score, it's a whole system. And it's made up of, the anticipation piece. So that's about anticipating, red flagging, patients who are high risk. And, things like safety huddles really enhance that. we're trying to anticipate. And actually, if you go back through medical history, anticipation was, I suppose, first acknowledged by Galen back in 173 AD, where he described an abnormal heart rate as, that precursor to death. So it's actually acknowledged as far back as then, and that really, I suppose, told us that we can actually predict, adverse outcomes or adverse events. We can predict when a patient may deteriorate. Okay. So also a part of the system, of course, is the recognition, then the escalation, and then the response to that escalation. And of course, then we must, that closed loop governance, where we have clinical bedside governance, but also the organisational governance.
Okay. And Yvonne, in your opinion, what do you feel is the most critical factor from, say, a staff perspective in applying the iNews system?
I think, first of all, we can't escalate if we don't recognise. And, how do we recognise? We must bring education and training and have workshops and study days and simulation, accessible. And, we also have many online programs that are accessible to staff, because that will enhance clinical judgement. I always remember, actually, as a staff nurse, I was a nurse manager, in a fracture clinic a few years ago, and one patient really stands out in my head about how we build on our education and knowledge, and we use that becomes, I suppose, more enhanced over the years. But a young patient I was looking after, he had actually a really nasty fracture to his tibia. It was an open fracture, and he had to have surgery, and then he had to have a vac dressing. So he actually had to come back to us quite a lot, weekly, for a few months. So we all got to know him really, really well. And we'd have, the banter, and, it was really nice to get to know your patients and see them, doing really well. But I remember there were always busy clinics, and sometimes they could be very task orientated. We were trying to get through that volume of patients, get through the dressings and the casting and the tasks. And I remember running into the dressing room to get something. I was in the middle of casting a patient, and I just spotted him at the corner of my eye. And usually he'd just give me this big, big salute and make a big deal, and we'd have a chat, and he was really quiet. He barely acknowledged me, and I remember thinking, God, that's strange. And the nurse who was doing his dressing wouldn't have known him that well, and I just said, hello, are you okay, are you feeling okay? And he said, I don't feel great, I think I'm coming down with the flu. And I said, oh God, look, it's really important, go home, rest, plenty of fluids, take regular paracetamol. And, kind of had that chat. It was flu season as well. So I went to leave, and we talked about this nurse intuition, but actually it's, I suppose, subconscious flags. His behaviour was off. His colour was actually terrible. So, and I had just recently learned about sepsis as well. There was a lot more awareness at the time. And of course, he had a potential source of infection with his wound, and so he was at risk of getting sepsis, and he'd had recent surgery as well, so that has an impact on his immune system. So I went back in and I did his vital signs, and he was very symptomatic, and he actually ended up in the high dependency unit for 10 days. He got a staph aureus bacteremia, and it was from the wound. But it was just, still the hairs on my neck stand up, because often I think, would I have stopped if I had known him? Would I have stopped to take that minute to look at him, to know his behaviour was off, his colour was off? Would he have went home? He lived alone. Would he have went home and died? Because he was really sick, actually, and he went on to deteriorate further. And that's why he went up to HDU. But he was an early catch because of, we knew him, but also that knowledge base that we had developed through education and learning, and these soft signs of deterioration, which are so important.
Yeah, absolutely. And I think that clinical judgment piece that you're talking about is so critically important, and that relationship that you had with the patient, that it went beyond just the clinical judgment, but it actually had that relationship aspect to it.
Absolutely.
How can you encourage people working in clinical environments to have that? Is that just part of your training, or is that something you can instill in people? Yeah. Is there...
I think it's a bit of that, but it's also culture. And I think we need to, support staff, that they have the confidence to escalate, especially escalate when they're worried about a patient, but they're not necessarily triggering on the iNews track and trigger score chart. I think that takes a lot of confidence. to be able to make that call. And I think, that's where we need to support staff. And, because we know from looking at national and international, literature and case reviews where, failure to escalate, it happens for many reasons. And it's, fear of looking silly, fear of reprimand, or it's not a culture that's encouraged. And I think that takes a lot of work, and it's something we have to continuously work on. And, we're always trying to embed that in staff. And also, I suppose feedback when they do escalate. Look, that was a good catch. That was an early catch. And I think that's where, going back to talking to staff or auditing will help as well. But culture and education and training will enhance that.
And do you think that having a score like we do in the iNews can actually have the adverse effect of creating complacency? So that if there was a patient that had a lower score, that people might be complacent about being vigilant about watching them and recognising a deteriorating patient, because deterioration, as we know, can happen so rapidly.
Absolutely, that's a really good point. And I think as well, so I think that there's multiple factors to that. I think one factor is that's where our data will be valuable. For example, one hospital I had dealings with recently, they looked at their cardiac arrest data, and they actually found that the majority of patients who had an unanticipated cardiac arrest had an iNews of 4 or less, which is really surprising because you're expecting those big high scores, 7, 8, 11, 12, and this is probably something that Christine might be able to attest to later on. And I think another side to it then is, again, going back to that, staff experience, that confidence. I remember a case I came across when I worked with the National Sepsis team. We used to do national audits, and a really good example of a case where a nurse escalated. The patient had an early warning score of 0, but she knew the patient was unwell. Because of the colour, the patient started to rigor. The patient was barely able to get out of bed compared to the day before, and also had to be, brought the commode, whereas he had been able to walk out to the toilet the day before. But she picked up the phone and escalated. She trusted her clinical judgement. She was a senior experienced nurse, and how she got a registrar up with an early warning score of 0. I suppose when we went back to speak to her, she knew the registrar, he knew her, they had that relationship built. He knew she doesn't ring on it, she's really worried about a score of 0. But she had the other, bits of information, like, colour, behaviour, and, the fact that he was rigoring. And actually that gentleman, the registrar came up straight away, reviewed the patient, but the patient actually ended up having a cardiac arrest while they were there reviewing. Had an ICU admission, but actually had a good outcome. So that patient got the best chance possible. And, because sometimes we can't save every patient, but it's about giving them the best chance possible.
Yeah, absolutely. And Christine, coming over to you, as we said, you're an advanced nurse practitioner. You're out there with the patients, with their families every day. Have you had similar experiences to Yvonne?
Yeah, we have a lot of similar experiences. I suppose one of the things that I wanted to say was kind of, patients are much sicker in the hospital than they have been historically. So, all patients are at risk for deterioration. If they were well, they wouldn't be in the hospital. So it's how do we pick those up? Because as you indeed said, not everybody scores. And then not every score needs the same response. So that's why not so much the score, but the response to the score and the response system becomes very important. And I suppose that's where my job comes in.
Okay, and tell us a bit more about this role that you have and kind of the genesis of the role.
Okay, so I'm what they call a critical care outreach A&P, which is a very long title. I always think it's kind of like I'm the person you can call for multiple issues. I work with a team of 7, just 7 now in the last year, really. So what we do is, originally we started in 2015 with just one person, and what I would do is go out and see all patients post-critical care, because post-critical care is obviously a time where you are fragile and you are at high risk for we used to say reoffending, or having to come back to the ICU. So the goal is to not have readmissions, because readmissions to intensive care actually increase your morbidity and mortality, and that's not what we want for anybody. So we started with that, and we started with only one person. So, you had to start, what was your patient base going to be? But we've grown that out to a 7-day service and 24 hours on weekends, so that we are a response for anybody that anyone feels is deteriorating. So it could be somebody with a high early warning score, and it could be somebody with a 0 warning score, but the nursing staff is worried about them. It could be somebody that the family is saying the patient is not themselves, which is probably one of the newer aspects of the system, and which brings some concern around it because people are worried that people will always complain. But it's not about complaining, and there's no complaining to it. It's they know their family member, and they know they're not themselves. And they've actually found that we did a recent study with an Aileen McKinley from Queen's in Belfast, who looked at getting families involved and interviewed patients post-deterioration and a family member to see, how would they respond, or would they have triggered a response if they were aware their patient was getting worse. And there's lots of literature out there that says patients do not overuse this. Nobody wants to. There's a fear of the cry wolf effect if you're getting too many calls or concerns, but that's not what's been found in the literature. So we want to allow anybody who sees a deterioration to be allowed to call us so that we can come out and assess them and try to find out, is there deterioration here? Because you need the facts to bring to the response team so that you'll get the highest level of response needed for that patient.
Yeah, and we know that, oftentimes it's the family members and the patients themselves that know they're deteriorating before even staff members do. And do you think there's opportunities to introduce that kind of escalation or flagging from patients and particularly family members in a hospital environment rather than just in the community?
Yeah, sometimes I think escalation is not quite the right word because but they need some sort of response to get an assessment to see if they need escalation. I think that's where we come in. And definitely, I think that, people, particularly with the older family members, one of the first signs is a change in behavior. Or the example you gave of the young gentleman, who you wouldn't really expect to be at high risk for deterioration, even though he had, because of being young. But he just, the first trigger was, God, he's not himself. So family members will see that first because we don't know what he's like.
So Christine, going back to the patients that are coming in that are at risk of clinical deterioration, who exactly is at risk? Okay,
I know I did say at one point that everybody's at risk, which in itself is true, but there are certainly patients that are more at risk than others. We know our elderly population is a high risk, and patients who have comorbidities, your COPD patients who require non-invasive ventilation. Like non-invasive ventilation was at one time only in specialty areas, and particularly post-COVID and with COVID, it is in every ward in the hospital. So those patients are at high risk if people don't understand the cues for when these things aren't working. Anybody who's had a critical care stay or a high dependency stay is at risk for deterioration. Patients that are not with their cohort group of patients. So if you have a surgical ward that has had to take overflow of medical patients, those patients are at increased risk, or vice versa. A medical ward that's had to take surgical patients, they are not with their cohorts, so they are at increased risk for deterioration. That's anybody who spends a delayed time in ED. ED is supposed to be for a short period of time, but because of bed crisis, they can't get beds, so that puts them at increased risk for deterioration, even once they get to the ward.
And why would that be, Christine?
Well, the ED, the whole purpose of an ED is to it's a triage system. It's to treat emergencies and to triage patients to other areas. So it's only supposed to be about a couple of hours of care. It is not set up to be about 12, 24, 48 hours of care. So it's how do we move that on and set up systems to be on high alert for those patients.
Okay, and what do you think, Yvonne, coming over to you, what do you think are some of the systems that could be implemented?
I think actually, listening to Christine there, what she was talking about was anticipation, the high risk patients, raising our situational awareness. And, a lot of the things Christine touched on are, cues for caution, that patient outside of their specialty area, the pregnant patient out being looked after in the non-maternity setting. And I think anticipation is something that, can be enhanced. We do it in handover, we do it informally, we do it when we're going on break, saying, will you keep an eye there, or have a patient coming back from theatre, or I'm not sure about the patient, they need close monitoring. And actually that can be done then in a more formal structure, with safety huddles, And safety huddles are, they're goal-orientated brief meetings, and they should be focused, and they should have a systematic process. And it's also important to monitor the effectiveness of the huddles, but also to be inclusive of everyone's voice. Have we got all the key stakeholders? Have we got all the key, team players? For example, I remember patients being escalated to me by healthcare assistants and actually a porter one time, and it was that early deterioration. So I think that's really important that we do that, we include everybody. So I think anticipation, and that's something we can learn and we can embed in our everyday practice as well.
Following our discussion on safety huddles, we moved on to a discussion on the iNews tool and the updates made to the current version 2, which was launched in September 2020. Part of our discussion focused on the practice of adjusting scores, which Christine explained. And I know there'd been some conversation on adjusted scores.
Yes. Excellent.
And I wonder, did that come up, and how did you address that?
This came up, and this is a
and tell us what it is
question.
first.
So
actually,
adjusting a score means, and there's good rationale for doing this in patients. So what happens is, if you come in and you're on 3 liters of oxygen at home, so we adjust your score that you do not score for that oxygen. And it is a rational thing to do. However, if you have an evidence-based score, you can't change the parameters on it or how you mark them. So that's kind of part number 1. Number 2, it would easily then not realize that if we're adjusting for oxygen, now the patient's actually on 5 liters, but that's been missed because we've adjusted for oxygen. So little things like that could happen. You could have somebody who's known to be hypotensive. For instance, I know I have low blood pressure. My blood pressure runs around 90/50. So when I go into hospital, I'm going to score. And any time I've had my blood pressure taken, it's rarely over 100. I'm very healthy, I'm very fit, but it's just low, so I'm going to score. So if we knew that was somebody's baseline, we'd adjust the score. But again, there's inherent things where if I'm sick, you would think maybe, or if I'm in pain, maybe my blood pressure would be higher. And it's the trend you have to watch overall. So you just want to be careful about adjusting scores. But then you have the cry wolf effect, because now my blood pressure is scoring a 3 or 2, I suppose. And maybe, I don't know, maybe I have a temperature and I'm scoring 1, and who knows. So all of a sudden I'm scoring a 4, even though I'm not that unwell. And the doctor comes down to see me and he says, well, that's her normal blood pressure, so you can take that score of 2 or 3 away. And they keep calling because my keeps scoring. So you get the whole cry wolf effect. So we have to try to augment that. So the things that changing is that we no longer adjust the scores. However, we come up with a monitoring plan for that patient, and that's probably the biggest change in it. So a monitoring plan means that, your score is 6, but you are okay. We're treating A, B, and C. So I'm happy that we do your vital signs for 1 hourly for the next 4 hours, as opposed to 30 minutes or 15 minutes. So you come up with a plan for that patient and highlight, but if this changes, I want another call. So there's a plan with a specific time limit on it.
Towards the end of our discussion, we turned back to the HSE's programmatic approach to improving the recognition and response to the clinically deteriorating patient, and specifically the work undertaken by the National Deteriorating Patient Improvement Programme.
So the DPIP programme, it stands for Deteriorating Patient Improvement Programme, and it's a patient safety initiative. And as you mentioned at the start of our podcast, that the deteriorating patient is one of the key clinical patient safety priorities. I suppose we're a small team of 4, and it's led by the force that is Evelyn Casey, absolute amazing person. And I suppose the aim is to bring the subject matter and improvement expertise to conversation on the front line, and also to work with acute services in a systematic and programmatic way, and to bring improvement and to update the people on the front line with new research, new initiatives, and to keep them informed as well. And I suppose it's about sharing of information across the acute hospitals in the country. And actually we saw that recently with our conference, our DPIP conference in April. It was not only a huge success, it was oversubscribed. We'd set up a virtual access, but it also brought that community together. And it really showed us, God, there's a real appetite out there for frontline people. They want to know how to be safe, to do the right thing, to keep their patients safe and them safe. And I think that was just, not only it was inspiring, but it's assuring. And I think that's important that we keep bringing that to the table as well. Keep having these conversations. And, and please God, next year we'll have another conference. And hopefully it's, bigger venue where more people can come in person so that they can network and connect with each other and support with each other and share their initiatives. Look, we did this here, or we did that there and it worked really well, or we tried this, it didn't work, or sharing of data as well. I think that's really important we do that and support it.
Following my conversation with Yvonne and Christine, I then spoke with Dr. Brian McCloskey at the College of Anaesthesiologists of Ireland. We explored the topics of safe systems and safe culture, as well as the importance of communication, and he offered some examples of work they have been undertaking in the Belfast Trust.
So when we talk about safe systems, what I think we need is to have systems that make it easy to do the right thing. And there's no doubt that iNews and News 2 have really improved outcomes for patients through the early recognition and escalation and that response to deterioration. And we share Christine and Yvonne's experience in having seen a reduction in cardiac arrests in our hospital and a reduction in unanticipated admission to our intensive care units. However, there are many more areas actually where patients deteriorate, not just from cardiopulmonary deterioration. And we focused in our hospital in a number of different areas. One is with respect to delirium, and the other is with respect to acute kidney injury. And we've done some improvement work around those areas to see if we can improve the outcome for those patients. So we know that patients are at risk of developing acute kidney injury in hospital from a number of different reasons. And we'd seen that throughout our trust. So we set up a multidisciplinary team with the laboratories, the doctors and nurses, pharmacists, and to look at how we could reduce the incidence of acute kidney injury. And the first thing we did in true quality improvement style was we wanted to understand our system. So we didn't want to jump straight to solutions. We wanted to spend some time in understanding where it was that we were seeing the acute kidney injury. So we looked at the results over a year from the laboratories, and we plotted those on a Pareto chart. And that showed us that actually the highest incidence of acute kidney occurred in our vascular patients. And I suppose that's not to be unexpected in that many of those patients have chronic kidney disease. Many of them have, are going through major surgery that puts them at risk of acute kidney injury. So we then set up a team with the vascular ward, looking at, well, how is it that we can start to recognize early acute kidney injury and intervene before it becomes more severe. So one of the things that we were able to do with the lab really easily was we were able to set up an early alert system. So whenever those bloods are processed, if there is a rise in the creatinine, and the system's wise enough to know that there's a rise in the creatinine that is a level 1 or a level 2 acute kidney injury, and that flags up on the system. And actually you can then send alerts to the ward or to individual doctors to say, your patient has a grade 1 acute kidney injury and there's a risk, and you can really focus in on those patients. And actually then the second thing we did was we worked with the wards in looking at all of those risk factors for developing acute kidney injury, use of nephrotoxic drugs, the fluid and electrolyte management. And over time, we saw a reduction in the incidence of acute kidney injury. So that's just an example of a way where the system made it easy to do the right thing.
And Brian, you mentioned about safe systems and the system being designed to do the right thing through improvement work and targeted improvement work. But earlier in our conversation, you mentioned safe culture as well. What exactly do you mean, in your own opinion, by safe culture?
Well, Roisin, for me, a safe culture is one where people feel psychologically safe to raise concerns, to report errors or near misses without fear of blame. And when harm comes, that we will learn from that harm and actually will support the people and the teams through that harm. But it also, for me, is a culture where there is civility. And maybe we'll talk a little bit about that in a second or two. And where we not only learn from harm, but we learn from when things go well. We learn from excellence. So if we wanted just to talk about one of the areas that's really important in the management of the deteriorating patient, it's around communication. And where we saw in our trust where harm occurred, where there was unrecognized deterioration, a lot of that was around communication. And where we see a breakdown in communication, it's often around 5 big areas. So number one is where there's a lack of urgency of communication. And that's there's the recognition of the deteriorating patient, and the escalation in the response is that there's an urgency in that response. The second is that there's a lack of critical language that's often used, so that the language is ambiguous, and we've got to be really, really sure of our language and use standardized language in a standardized way and have a structure. And that's the third, there often is a lack of structure of reporting and of responding. And both Yvonne and Christine mentioned SBAR. And SBAR is a really good way of having a structured communication method. The fourth breakdown in communication is a lack of confirmation, is closing the loop, making sure that whenever you have reported or you've escalated, actually that you understand what's going to happen at the other end. And the fifth, and for me, maybe one of the most important areas of communication, is that there can be a lack of mutual respect. And that's really important, actually. That lack of mutual respect can result in patients coming to harm. That lack of mutual respect can be a really important barrier to patient safety. And we cannot underestimate the importance of civility. Perhaps the person who articulates this most really powerfully is Dr. Chris Turner in his campaign, Civility Saves Lives. And Chris, I would really recommend that you look for some of Chris's podcasts. And actually, Chris is coming to the Belfast Trust this September. We have a Safe-tember every year where we focus in 2 times a year, do it all year, but we focus in on Safe-tember, and we focus in March, and we have March to Safety. So this Safe-tember, Dr. Chris Turner is coming to talk about civility saving lives. So how we treat each other is really important for our patient safety. No matter who you are or where you are in the organization, when we treat each other with mutual respect, we help each other become the best form of ourselves. And we know how that feels, actually. I know how that feels to be working in a really high-performing team where, you might be dealing with really sick patients, actually, but everything goes well. And that you see that mutual respect between doctors, nurses, and all the allied health professionals. And when it goes well, it feels good. But actually, when there's a breakdown of communication, when there's a lack of respect and a lack of civility, that can lead to harm. And Chris has actually, pointed out that you can measure the effect of a lack of civility, because, whenever someone is either mildly or moderately rude to you, it takes away some of your cognitive function. So you don't have that bandwidth to concentrate on your patient. Part of it's thinking about that, and dealing with that rudeness. And actually that, you can see that resulting in patients coming to harm. So that you cannot underestimate the importance of civility.
My discussion with Dr. Brian McCloskey then moved on to the subject of learning from excellence and capturing that learning to share and spread improvements.
I suppose there's 2 ways that you can think about safety. And this is sort of, this is when we think about what safety 1 is and safety 2. Now, I'm by no means an expert in safety 1 and safety 2, but my very simplistic thoughts about safety 1 is that it focuses in on when things go wrong and focuses in on harm. And it's really important that you do that. But safety 2 is about focusing in on when things go right. And actually, there's as much to learn from when things go really well as there is to learn from when things, don't go as they are expected. And what we're doing in the Belfast Trust, and actually we've learned from other hospitals, we're introducing a system of learning from excellence. And learning from excellence is actually, it's a movement. It's a campaign championed by Dr. Adrian Plunkett. And this is about capturing that learning, capturing when things are done well in a systematic way. And also, as important, is recognizing both the teams and the people who have done really good things. And it's often about how you cope under adversity, because our systems are so complex. Actually, it's not that it's not that every system works perfectly. It's actually the workarounds. We need to learn from those. So what we've done is we've set up a system of QR codes. So right around our quite big intensive care unit, we have posters with a QR code on them. So you can click your phone on the QR code that takes you straight through to Microsoft Forms. You can input what you have seen, or you want to recognize a team or an individual, or you want to recognize something that went really well. And we can actually then look at all of those responses over time and start to theme them and start to theme about okay, well, what is it that team was doing that, how did they do that really well? And what is it that every other team can begin to learn from that? And then we can start to spread that improvement. We're now starting to spread this right out across our trust. So we're working with our IT colleagues in developing an app so that we can have a single scalable solution that we can use right across our quite big healthcare organization, so that we can capture the learning right across the trust.
So Brian, having that shared learning and learning from excellence across the trust, what do you think are the benefits?
So I think you've got to look at safety in a really systematic way. And you've got to focus in on different areas. And if we can theme that learning from in one area and another area, and actually begin to share that learning, that's really important, because often in big organizations, actually, one ward might not know that another ward is doing something that they're having problems with, and they're doing it really well. So it's about theming that excellence and actually spreading and scaling up that excellence.
At the end of our conversation, Dr. McCloskey advised me of the National Patient Safety in Anesthesiology Conference taking place at the College of Anesthesiologists of Ireland on the 11th of November 2022, where they'll focus on safe systems and safe culture. This year, they will have Professor Charles Vincent, who is a world leader in patient safety, and will discuss how we can monitor and measure patient safety. For more information on the conference, please visit the College of Anesthesiologists of Ireland website. And with that, we've reached the end of this podcast episode. Thanks for joining today, and as always, please remember you can listen back to this and other episodes wherever you get your podcasts. And please subscribe to get notifications when new episodes are added.